Waiting for maybe one more minute to get everyone to join, and then we'll get started. Okay, I think we're gonna get started, and just while we do our little introduction, and if more people come in, then that's great. So, my name is Ali. I'm one of the members of the Canadian Social Prescribing Student Collective. Thanks so much for coming out to this webinar. This is being hosted by the Canadian Social Prescribing Student Collective Medicine Working Group. We're dedicated to advancing research, education, and advocacy in social prescribing. This is just the first event in our speaker series, and we have many more great events with speakers working tirelessly to make social prescribing a reality here. We're always open to new members and new initiatives. So if you're interested in joining our team or learning more, please reach out to us via email. I'll send the email in our chat, and you can get in touch with us there. For our event tonight, we'll start off by getting to know our guest, and then we'll have plenty of time for your questions, comments, concerns, and suggestions. You can post them directly to the chat, or we'll actually have a Slido link for you to post your questions and stuff in there. So please feel free to do that throughout the webinar. Without further ado, I guess I'd like to get started now. We can introduce you to our esteemed guest, Dr. Kate Mulligan. She's an assistant professor in social and behavioral health sciences at the Dalla Lana School of Public Health at the University of Toronto. She serves as the scientific director of the Canadian Institute for Social Prescribing, a national hub dedicated to advancing community-led action on the social determinants of health. With a rich background in public health, Dr. Mulligan has been instrumental in implementing Canada's first large-scale social prescribing projects aiming to bridge the gap between clinical care and community resources. Her work emphasizes the importance of holistic approaches to health, recognizing the vital role of social and community factors in individual well-being. Dr. Mulligan, thank you so much for joining us this evening.
Thanks so much, Ali. And thanks everybody for being here. Should I just go for it?
Yeah, please. Floor is yours.
Okay, hi everybody. I have a few slides just to level set and get us started. And then I want to spend the majority of our time really learning from you about where you're taking social prescribing in your contexts, and answering any questions you have about the work that we do at the Canadian Institute for Social Prescribing, or in my research, or my advocacy and sort of policy work. So I'll start with just this opening part here where I can just introduce you to social prescribing and to the work of our institute. So you can see that okay?
Mm-hmm.
Yeah, okay, so it was in 2022 that I started the Canadian Institute for Social Prescribing, based on work that I had done in the few years before that. So starting back in 2018, which is around when social prescribing also started becoming more popular as a term and as a way of doing things internationally. So I was involved in the first pilot project about social prescribing, which tried it out in 11 community health centers all across Ontario, where these are primary healthcare organizations that, in theory, are already offering both clinical primary medicine and also community development and health promotion services. But what we found was that those two sides of the house weren't all that well connected, and particularly not through any kind of direct referral. So we tried out social prescribing, and we had fantastic results. You can look them up. It's a project that's called RX Community, Prescription Community, and our report came out in 2020. We found a 49% reduction in self-reported loneliness for participants. We saw that physicians and other healthcare providers reported big decreases in the number of primary care visits for people who were attending more for socially related needs than for medical ones. And we found that people enjoyed it. They felt a sense of purpose and meaning as healthcare providers and as participants. So I quickly realized this was something that we should be spreading well beyond those 11 community health centers and right across our country. I'm a health geographer by training. I'm very interested in our relationships with places. Why do we have different health outcomes in different parts of cities or different parts of the country, different access to healthcare? And how do we relate to place? And so for me, social prescribing is very much about the community scale. What can we do locally in our neighborhoods and in our communities to build resilience as individual people, as people in relationship with other people and places, and as a scale of the healthcare sector that is very dramatically under-recognized. So there is a lot of work that happens by community organizations, unpaid caregivers, and others that really does shore up our health system as it is now. But they're not paid that way, they're not recognized that way, or respected or resourced that way. But social prescribing is a way to help fold that work better into the healthcare system. So I also do a lot of work on advocacy. So I teach in public health advocacy, for example. And this is a framework that I use a lot in that work to help guide systems change, which is really where I focus a lot of my energy when it comes to social prescribing and community leadership in health. And that means focusing on things like what's going on in our local communities, that sort of the top layer, the big layer of that inverted pyramid. The kinds of things that you might expect as a more mainstream policy researcher and worker, things about how do we change policies? How do we change practices, which is where many of you who are health med students are really thinking. How do we change resource flows to provide funding to where it's most needed? And then I'll just skip right down to the very bottom, the mental models. This is something that, you've encountered in academia, people who think we've got to really transform the way we're thinking about health and medicine. And all of these layers are very important. And when we think of complex adaptive systems, we want to support work in all these different areas for different people with different strengths, different disciplines, different social locations, and all those kinds of things. But the place where I spend most of my time and energy is at that relational level, thinking about power dynamics and thinking about building relationships and connections. So getting to know who's doing what in healthcare systems all across the country, helping people build better connections between healthcare and community services, and really helping people to do that work of collaboration and working together, recognizing that we have different amounts of power at the moment in the system, and that's something we want to change. So very quickly about social prescribing, I'm involved in lots of different projects that tackle social prescribing for different populations. So for example, we have some new work happening about social prescribing on campus, and you can look this up at our Dalla, Lana School of Health, Public Health to find out a bit more about that. Some of you might already be involved with that. We have social prescribing work happening with Indigenous communities, by and for Indigenous communities, by and for Black populations, and with the recognition that there are many people who have been folding in social determinants work into their idea of what health and healthcare is for a long time. So social prescribing isn't a brand new idea, but it's a way to help systematize and resource this really good work and make it more accessible to more of us. I'm involved in a lot of research as well. So this is something that's available on our website at the Canadian Institute for Social Prescribing, an evidence and gap map about the effect of social prescribing for older adults. It's very comprehensive if you want to get a sense of what's out there with respect to the evidence. It's interactive, so each of these dots on here you can click on, you can find out about evidence quality, you can directly link to all the studies themselves that were included in this, and you can get a sense of where do we have a lot of evidence and where do we need to build more evidence when it comes to social prescribing. And so, for example, we look at outcomes at individual and community levels, we look at different kinds of activities, and it's all in there. So another place where you can just have fun, those of you who are into the evidence, to have a sense of what's out there now and where we're headed. Just today, we put out a new resource along with cascades about social and nature prescribing, how we can use that to help reduce our environmental impact and connect people to their local nature. And we've done all kinds of other stuff too. So for example, I have a new piece out in Maclean's magazine that came out last week, making the case for social prescribing, describing what it would take policy-wise and resource-wise to make it happen across Canada. And we have a study out with KPMG, Canada Management Consultants, about the social return on investment. So if we invest $1 in social prescribing, we expect to see a return of $4.43 in health cost savings, and also benefits from people participating more in our economy and in our local society. So that was a very whirlwind tour of some of the things that I'm doing, trying to support people doing social prescribing in practice, in research, and in policy to advance different kinds of systems change all across the country. But what I'm really most interested in is that relationships part and supporting the work that you're doing. And so I want to get to know you. I want to get to know what questions you have about social prescribing. I want to get to know what it might look like where you are, or where it could look like in the near future where you are. And I want you to know that as medical students, and I know you're not all medical students here in the room today, but most of you are, many of you are, that you can reach out to me and that we can talk directly, and I can try to support the work that you're doing in real time. And that's what I really love to do most. And I realized, Ali, that I didn't describe what social prescribing is. So maybe I'll do that really quickly before I turn it over to everyone. Social prescribing, everyone. It means a referral between healthcare and community services to help address all those needs that are rooted in the social determinants of health. Upwards of 80% of our health outcomes are determined by things like access to housing and food and social connectedness and all that stuff. But it is not just about the end social prescriptions being directed to a community organization, an art class, a walk in the park. It is as much about social prescribing as a process and as a relationship that involves health promotion, really focusing on empowering people to make their own decisions about their healthcare, to leverage their own capacity and expertise, to build their self-determination and sense of purpose and sense of belonging. And so the process of accompanying people and supporting them through social prescribing is the part that for me is really transformative, that helps us flip the script from what's the matter with you, which is the more biomedical gaze, to what matters to you, and to help you follow through on that. And I think importantly in our health system right now, that you matter. You're not just facing a big bureaucratic machine that doesn't care about you or doesn't have time for you, that we can pause and really listen to what's important to you and help you reconnect with what's most important, that helps you build more control over your health, which is Health Promotion 101. So that's social prescribing. Sorry, I came with that at the end.
That's totally okay. Thanks so much for outlining the definition of social prescribing, but also all the efforts that you've been making from your neck of the woods in Toronto and outwards from there. I guess a first question for you, everything you are advocating for sounds amazing, but we're kind of curious as to what barriers you faced when you're trying to advocate for social prescribing, and how have you responded to them?
Yeah, so great question. And I think one of the things that I'll say is, as you've probably noticed, I have a bias toward optimism. And so that means that I really take seriously the ethos of social prescribing that is a strengths-based approach, an asset-based approach. So really starting with what's strong with us more than what's wrong with us. So yes, there will always be barriers with respect to getting enough funding to make this happen, having community organizations willing to engage with healthcare, even though they might have historical reasons to mistrust healthcare, or be worried about, being sort of colonized by bigger health institutions. Maybe people misunderstanding what social prescribing is about and just focusing on the referral part and not the health promotion part. Those are all, potential hiccups and challenges along the way. But I gotta say, it has been amazing the last several years. Actually, people are really ready for it. People in healthcare and on the community services side really want it. If I talk about it, like in the media, on the radio, people will call me up, they will find me, and they will say, I need this for my mom. I need this for my neighbor. I need this for myself. And they can see the equity considerations and how it can be tailor-made for different populations, different people. And now, since 2019, we now have some local social prescribing initiatives, or regional, in every province across Canada. So it's growing fast. The appetite is absolutely there. People are finding me, like this Maclean's article. It wasn't my idea. Maclean said, will you please write something about social prescribing? It's out there. in the discourse. You're hearing about it. That's why some of you are here. You're leading the way to make it happen. This is the trend in healthcare generally toward better addressing social needs. And social prescribing is not really an end unto itself, but a tool that we can use to help better knit those together, and also to track and evaluate the impacts. So we can use, putting it in people's health records to get a sense of individually what happens when we make these social referrals and do what I call the precision community medicine. So you med students, you know about precision medicine when it comes to genomics, but that we can be precise about people's social health too, and we're ready for that now, and that's pretty exciting. So overall, the barriers are much fewer and further between than you might expect. People really want this, and we're honestly taking our time and just trying to sort of manage demand and build up slowly in a way that we don't go faster than we really have capacity for, and just be ready to keep that grassroots flavor of social prescribing that really works together equitably and equally with community members and patients. Because if we go too fast with a top-down approach, we risk losing some of that. And so it's okay to be taking our time.
Yeah, thanks so much for that. Clearly, I mean, if Maclean's magazine is reaching out to you and asking you to write a piece for them, it means that, the higher ups are starting to hear about this, which is awesome. What do you think makes social prescribing limited practice here in Canada? We recently wrote an article, and we had lots of references for the UK, for example, and the things that they've been doing out there, but it's a little bit more limited out here in that, physicians might not know about it, other healthcare professionals might not know about it.
Well, I think one, it might be a bit more limited, and that's partly because in the UK they had a top-down government investment where they said you're going to do it now, and so yeah, they're doing it now. So they have a few years jump on us. But the other reason, that one of the main reasons, and one of my missions in life to change, a lot of the work that we do just isn't on the record. So people aren't publishing it. They're not, framing or thinking about it as research, especially the small community organizations and primary care. They're busy surviving, right? They're just doing it. And so that's a huge contribution that students and early career professionals can make, helping to just get some of this on the record. It doesn't need to be super transformative research. It needs to be descriptive, and it needs to get it out there. So for example, a couple of years ago, Dr. Teresa Tam, who's our Chief Public Health Officer, asked me to write a paper about the future of community and community engagement in public health for her report on a vision of public health sort of post-COVID. There were three other researchers commissioned to do reports, systematic reviews essentially. One was about Indigenous health, one was about data, and one was about governance. They all had bodies of research that they could go and write up, but community engagement and health equity, I just couldn't. There wasn't enough in there in the Canadian context. But I know, because I have worked in public health as a public health professional, and I have worked in primary care as a primary care professional, that this work happens. It happens all the time. There's lots of really great stuff happening. It's just not in the scientific literature. And a lot of it's not even in the gray literature. So I would argue that it is happening more than you think. People don't necessarily call it social prescribing. And what really is most important is they don't do it systematically. It's ad hoc, it's whatever's available locally, there's maybe one champion who's really into it. And that's what we really need to change. So we need to systematize it and make it part of routine, regular practice. So yeah, we still have a ways to go, but we're doing more than we think. And your contribution by writing that paper, that's the kind of thing we need lots more of to get this stuff out there on the record and to get people seeing that it's happening.
Yeah, thanks so much. I'm curious, just as on a personal note, I visited a social prescribing group here locally where I am, the North Okanagan in BC recently. I was wondering if you've noticed any differences between the way social prescribing is being implemented or how it's working on the ground level from one province to another, from one community to the next.
Great question. And yeah, there are differences, and that's a good thing because social prescribing is so context specific. It should be specific to the strengths and the needs of communities and the strengths and the needs of people in those communities. So yeah, there are some differences. I think one of the big differences is that BC funds social prescribing provincially. So there are link workers funded by the Ministry of Health particularly focused on older adults. And in this sort of home and community care space, providing housekeeping support, providing community center-based activities, and also linked to healthcare. So funded through the United Way to tiny community organizations that are also linked to regional health authorities. And so can do things like help people with hospital to home transitions and that sort of stuff. So that's amazing. And that happened in part because BC's community sector organized. They got together and they started to build relationships with the Ministry of Health. Particularly, this is what they call themselves, the community-based seniors serving sector. They got together and built that relationship and showed over time what they needed. And so when an opportunity for something like social prescribing arose, they were ready for it. And they had a trusted relationship with the ministry. In other provinces, there is less provincial involvement. So we've seen some really interesting examples that were funded in the short term by the Public Health Agency of Canada around mental health post-COVID for equity deserving populations. But those were short-term ones, and some of them have already ended if they didn't have good sustainability plans in place. There are other provinces that are on the verge of funding social prescribing. And of course, there are philanthropic funded projects in every province. And that's where, there are some funders that are very interested in this, and they're making it happen for specific populations or communities or those kinds of things. So it does vary. It depends on the local context and the needs. And like I said, I think that's a really good thing. I do a ton of work on health equity, and you won't be surprised to hear this, but really the main domain of health inequity in Canada is actually geography. So people who are living in rural and remote areas just face much bigger challenges in accessing healthcare. And so we want to make sure that the rural and remote communities have what they need to do community development approaches to build new services where they're needed and that sort of thing. So I'm okay with that looking really different. I don't want there to be one single model for social prescribing, but we do have some shareable tools that give you the basic model of the kinds of things that go into social prescribing.
Yeah, I guess you alluded to it a little bit earlier. So these provinces that are maybe not doing such a great job of implementing social prescribing right now, what steps do you think they could take to improve access to it for their populations?
So one of the biggest challenges for health planning work in Canada is that we have a very much like an emergency crisis approach. So we have to put out this emergency fire here, which is nobody has, or many people lack access to primary care to begin with. Right? Or other big health human resources challenges. So that's one of the biggest hurdles, I think, is sort of helping us to plan like slightly further ahead. And that's one thing I really like about social prescribing. It doesn't ask you to immediately change your mental model. Remember the bottom end of that pyramid to suddenly you're investing in tons of prevention. Like asking people to do that just doesn't happen. But if we say, here's a tool you can use that relieves a bit of pressure on primary care, people might be interested in that. So there's good data that says primary care practitioners and specialists, healthcare folks, feel better when they do social prescribing because they can reconnect with the things that made them interested in medicine in the first place. You're still connected to that. Other people who are out in the workforce, they face burnout from administration and tons of pressures, and that idea of like rushing people through all those kinds of things that are counter to what you care about usually. So this helps you to either directly connect with people about some of that stuff that matters, or refer them on to a link worker who has the time to do that. And then you can sleep better at night knowing the people that you're worried about are taken care of in a better way, and that you get back to that sense of purpose and meaning in the work and all those kinds of things. So then my advice, I think, for those next steps is to build the research and practice and experience to show how social prescribing can help ease some of the immediate pressures. And then while we're there, we'll get all these like sort of co-benefits that when we'll be on the road to positive feedback loops and learning that keep us improving in quality and continuing the work. So it's like starting with practice changes and tools, moving toward mental model changes that you just get by experience. Like one of my favorite things about social prescribing is that people love it. If you went to see a practice, you probably heard people who just talked about how great it was and how awesome they felt. Like that is great, right? So we want people to keep feeling those good feelings and keep moving in those direction that gets us more of those good endorphins and whatever, all those, you'll know more than I, what's going on physiologically when we feel so good about social prescribing.
I don't know. It's pretty late in the day. I'm not sure if I remember all the different new exam sitters, but yeah. Well, I mean that's excellent. That's excellent advice. Um, Part of the speaker series that we're hosting this year, we're trying to see if there's ways that social prescribing could be used to address the homelessness crisis. Wondering what your thoughts were on that. Like, how do you think it could be incorporated in a way that we're addressing the root causes of homelessness in the first place?
Yeah, okay. So that's like one of the number one challenges facing us in Canada right now. Like social prescribing on its own is not going to solve homelessness, right? Because we often say, my friends in the UK say with social prescribing, you don't want a situation where you have too many travel agents and not enough holiday destinations. Like if we don't have enough homes to send people to, all the social prescribing in the world isn't going to change that. So there's a supply problem, right? But that said, there are social prescribing approaches and social medicine approaches that can help. So you probably know my friend Andrew Buzari, who has led a social housing initiative through University Health Network, which is Canada's biggest hospital. They have a new supported housing building that's going to house several hundred people who were otherwise going through the revolving door of the emergency room, costing more money and not being well served. And everybody felt bad about it, right? So now those people can be referred to housing. So that's a form of social prescribing. It's a highly, highly resource intensive form of social prescribing, though, right? And most of what I do is more focused on breadth and simple solutions that are a bit more upstream for people who are not yet in crisis. The other model that is very interesting is happening in Ottawa. And there is a Housing First initiative. So Housing First is a model of healthcare that says, get people homes, get them stabilized, and then you can address their other needs. What they found was, though, that people who got Housing First still were really suffering. And why they were really suffering was because they were lonely and socially disconnected. And so they have really worked on incorporating that ethos of social prescribing into the Housing First initiative. So alongside being prescribed and supported with housing, they're also supported with reconnecting with their communities, having a sense of belonging and mattering in the community, having a sense of purpose, something to offer, something to give. So you don't just see yourself as a recipient of services or somebody who needs things, but as somebody who has something to really offer. Those kinds of changes are the ones that help people really take more ownership of their health and not just be receiving new services. So yeah, social prescribing is part of the bigger conversation about the kinds of communities we want and how we support people, but by itself it can't solve some of those big resource and policy challenges. But the last thing I'll say is it can help provide better data. So it can help us to know exactly and precisely how the housing crisis is impacting healthcare. People who are underhoused or unhoused, are they coming to the ER for all these kinds of reasons? Are they seeing their primary care specialist more often? Or are they not coming in and then later coming in with way more advanced health challenges, right? So better describing the relationship between these social needs and the use of health services is another piece of it.
Yeah, I mean, definitely a bigger problem that than just social prescribing you
Yeah.
know, can tackle. But yeah, thanks for that. Um, Us in the social prescribing student collective, we were obviously drawn to this practice and we came to this group from different kind of paths and journeys, but for the most part, it's not really a part of the medical school curriculum for now, and that is definitely one of our goals going forward. We want to make sure that this gets incorporated into medical education curriculum so that practitioners in the future will know that they can send their patients to programs like this. Do you have any suggestions, any ideas on how we could work towards this goal, how we can make it more palatable for medical schools? Like, what do we actually need to teach students?
That is such an important question. And I think you're already doing it. My experience is that there's huge demand by students. Like some people are going in expecting this to already be part of the curriculum and then sort of being surprised that it's not there. And really having you have a really different lived experience from your instructors, even from me, right? So when I was going through the age and stage of, I went to school with a lot of people who went on to medicine. And, we didn't really have exposure to research about health inequities. and the kinds of things that I went to later on to study health geography about. We didn't have positionality and intersectionality as considerations in our everyday lives that people talked about, that you probably just talk about with your friends and family as a matter of course. A lot of that is just different. You've had the lived experience of COVID, you've seen equity issues in action, you have an analysis of colonialism, right? All that kind of stuff that's like fairly normal for you. People in my age and older had to really fight to kind of get in there and put into the mainstream for conversation. So that is all to say that like we have to be a little bit empathetic for the people who have different ideas about what health and medicine are about and medical school are about. Some of it, they say that it takes 17 years for a research innovation to actually come into practice. You know why that is primarily? It's really like the life cycle of a physician. So it's like partly it's just a generational change. It's partly about how long it takes, but really honestly, a lot of it is just about aging out. So, what in a very short time, you are going to be where I am and you'll be the leaders and you'll be mainstreaming a lot of this stuff. So part of it's just going to be time. The other thing is there's a huge emphasis on primary care and primary care teams right now in Canada. And so med schools are already thinking about this. They're thinking about how do we better serve our communities? How do we think about training up physicians who are going to stay, who get the community, who understand, speak the language, like literally and symbolically. And so the new medical schools are a really good place to start also. So I know SFU has a new medical school. TMU, Toronto Metropolitan University, has a new medical school. U of T has it. Scarborough has a new medical school. There's probably others that I'm not thinking of right now. So those are really good ones because they have a blank slate. They can start fresh and come up with a new way of doing curriculum. The other ones that are more established, and you know who they are. You know what their reputations are. Some are more conservative, some less so. The one at where I happen to be sitting is, pretty conservative. So different, but they're always, champions, even in very, very mainstream settings. And so I hope that you'll also consider inviting my friend Gary Block to come and speak to you at some point. He's a physician at St. Michael's Hospital, and he is involved along with CSP, the Canadian Institute for Social Prescribing, on some work now that is all about med school curriculum change and really thinking about it. He's a physician, he does social prescribing in practice. We work closely together. And so it is starting to happen. And what you can do primarily is ask for it, like demonstrating demand is a huge part of it. But also bring what you're learning in places like this into your assignments, into your rotations, into the work you're doing, so that the people who are less exposed to it, who are older, can learn from you. And most of them will really want to, I think. There is an openness and an appetite for the most part for this kind of thing, but people feel a little bit overwhelmed. And so part of your job will be to help normalize it and ease the way for people and show that it's not too hard and it's not too weird and it's evidence-based, and that you can speak the language that they speak about what's most important to them, that there's evidence, that it's safe, that it will make their lives easier and not harder, right? All those kinds of things that a clinician cares about in their busy, hard daily practice.
Yeah, and just, I guess, lastly from our end, is there some way for us to be more informed about the kinds of things that are happening in the social prescribing space, both on a domestic level as well as internationally? Are there certain organizations we should be following? Is there something really being done super well overseas that we need to know about?
Not really. Still all pretty new. We have a global social prescribing collaborative. I think that's what we're called, but it's just kind of a community of practice. We have communities of practice in Canada. So, I mean, the student group is way ahead in a lot of ways, but there's also a group for implementers who are out there doing this from different types of health professions and community spaces. And there are national social prescribing organizations in many countries, including Australia, US, Singapore, UK, and several others. So you can, Google around and sort of see what they're doing. But yeah, we're really making the road by walking here. So you're still at the very, very early days of this, and you can influence kind of where it goes from here. I'm really trying to help build up the research evidence base, get more people talking about it. CSP in general is trying to support implementation, making sure people have what they need to get started. And so, yeah, that's kind of where it is. Oh, and the last thing I'll say though is that our friends and colleagues in Singapore have recently become a World Health Organization collaborating center on social prescribing. And generally, the Western Pacific WHO has been a leader in this. So we will start to see more international global level leadership coming out of the Western Pacific region on social prescribing, and we're part of that. We're connected in with them. So yeah, I wish I had like some other like amazing resource that's hidden away, but yeah, this is it. You're looking at it.
All right. Well, it's a great start, and we're eternally grateful for the work that you're doing, spreading the gospel here. Yeah, I think this would be a good time to open it up to questions from our participants. There's actually one just in the chat right now. One of our participants is asking if you have a link for the pilot project taking place at U of T. Seeing as you're there, you might know that one best. I understand it to be the project targeting homelessness, but
Are you talking about the student on campus social prescribing?
There was a meeting I feel like a couple of months ago, like a noon hour session that I think was hosted by U of T, and so they're looking at piloting social prescribing directly on campus and then documenting the research and stuff.
So we don't really have a website, but it's my postdoctoral fellow. Her name is Nicole D'Souza. So I can put in the little media article about it, and then you can reach out to me or Nicole directly, and we can tell you more about it. We're kind of just at the very beginning of this, but we have a SSHRC grant. Oh, there it is. Thank you, Jeffrey. We have a SSHRC grant to start this work at U of T, and we have some other grant applications in the hopper to help try to grow the work on other campuses.
So I'm University of Waterloo, so yeah.
Okay, reach out, because again, our experience is whenever we reach out to like campus health services, they really want to do this. Everybody's ready. Everybody sees the huge need, especially for mental health, for post-secondary students. You're living this, you know what I'm talking about. Even though theoretically you have access to way more services and supports than anybody else on campus. You've got clubs, you've got health, you've got sports. You still have like absolutely terrible mental health outcomes. So what's going on, right? How can we provide better support? It's not just about having access to these resources. It's about helping you use them in a way that's meaningful for you.
Okay. Thanks so much, Zelda, for your question. We've got another one here from Niku. What are some contexts in which social prescribing works best, and are there any prerequisites that need to be in place for social prescribing to work well? You brought up, Singapore and the kind of Asia Pacific area being particularly good at this, and we're wondering if there's anything that they're doing that makes social prescribing work so well there.
Okay, well, like Singapore has a really collectivist culture, so that's part of it. So it's like if they say everybody here in this organization, we're now going to do social prescribing, everybody just mobilizes and does it. So there's an underlying culture that helps. So that's working well. In the US, some of the things that they do really well are the referral side. So there's a longer history of social screening and referral. There's a longer history of things like Andrew Brazzari's housing initiative, right? Like they do that, hospitals are building housing there. And the reason is they have something called accountable care. And that means they don't get paid unless they actually improve population health outcomes. And they can't move population health outcomes without addressing social needs. If you just overinvest in acute care and high-tech stuff, you're actually not going to move the needle on population health and health equity. So once they had to be accountable for outcomes, they changed their practices and really focused on this. So they do that really well. They don't do the self-determination and health promotion part as well. They haven't really thought about that part as much yet. And then in the UK, what they do really well is try and have equitable access. So really, blanketing the country with lots of these kinds of initiatives and requiring that primary care networks do this. So there are different lessons in different countries that have sort of taken different approaches. I think here in Canada, we have a decentralized health system. There's not one health system to influence. We have multiple, right? All the provinces, plus Indigenous healthcare, plus certain federal responsibilities in health, certain municipal responsibilities in health, and so on. And so it's really challenging for us here to make sort of a big blanket change the way that they could do across England. But one thing that we do very well and have an excellent reputation for is health equity. So really starting with equity at the center of our thinking, engagement with communities and the leadership of communities and patients in the thinking, and really building in some of that from the beginning. And so that's where we have lessons for some other countries where, so for example, in the UK, they didn't really focus on health equity early on. And then COVID happened and the Black Lives Matter movement happened and other things that made them recognize they were missing out. And they also learned that through experience. So their link workers were sort of recruited on the basis that they might be sending people to knitting groups and gardening clubs, but they were faced with people who were facing fuel poverty, domestic violence, mental health crisis, like just way bigger kinds of concerns that they hadn't really thought through. And so that was hard. It was hard for the link workers. It was hard for everybody. So we can help. We can help with that because we really center some of that more fundamental, deeper social need in social prescribing, either directly or indirectly in terms of being able to refer people onward to social workers and others who have better training to deal with serious crises, which social prescribing isn't so much designed to do. It's a little bit more upstream. So different places have different approaches. It's really hard to say what works best, but I think what generally works best is starting with what's strong in your community. So doing an asset map, finding out what services are available and where people are willing to take leadership and collaborate and come together, and starting there. And then just really continuing to grow from there, and then being open to policy windows and other opportunities when they do arise.
Yeah, love it. The strengths-based approach.
Yeah.
That's great. We have another question here. So we have a social prescribing practicum student in British Columbia who's wondering what absolutely needs to be included when measuring outcomes for a standardized follow-up process or survey in community connectors.
That is a great question, and I teach program evaluation, so thank you for asking it. I am a little bit unorthodox when it comes to the evaluation. I really think that there are not too many must-haves. And that's partly because community organizations don't have a culture of or a capacity for evaluation very much. And you might be experiencing this in your practicum. Healthcare folks are used to this and have the tools and supports and culture and training to do it. In community, we just don't. So we have to be very realistic about what to ask of people, what they're capable of doing in addition to their, survival work that they're doing. And so I have been working really closely over the last year with Healthcare Excellence Canada, which is an organization that supports lots of small innovators across the country to do different things, and working on a common evaluation framework that can really help us think about the aggregate impacts of all kinds of small community health interventions, including social prescribing, but other stuff too. And here, I really envision people having guided conversations where you use whatever evidence you do have to help you answer some key questions. And they're really, over time we'll get into more specifics, but they're really about some key things that we want social prescribing and community health work to do. Have we shifted power to community in some way? Have we funded a community-based link worker? Have we given more money and support to those community people? Are we thinking locally in a new way? Have we used that health promotion and self-determination lens so that we are really helping people build their capacity in new ways as patients and as community members? Have we helped move the bottom line for healthcare decision makers and funders? So that's things like the quintuple aim, right? Better use of resources, better health outcomes, better equity, and some of those more systems measures that you might be more accustomed to. And have we built more of a learning health policy system? And that just means when we're doing evaluation, are we thinking about and including the voices and needs of people, patients, implementers, providers, but also those funders and decision makers, so that we're maximizing our time and resources when we do evaluation on the most important things. So some people will say, you really got to measure self-reported loneliness according to the UCLA loneliness scale. Or you got to measure, very specific health, human resources, healthcare burden outcomes. Or Healthcare Excellence Canada, they have to report to their funder, which is the Government of Canada, reduced ER admissions, ED admissions, or changes in ALC stays for people in long-term care. So sometimes there are some really concrete things that you must do, because that's the thing that the people who make decisions need to know. And there will be some concrete things that you need to know because they're important to you locally. But overall, I try not to focus on any specific indicator and focus more on those big questions and the big outcomes. And you can use whatever data you've got to justify your decision. That might even be expert opinion, to justify your sense of kind of in general how you're doing and the progress you're making on those. That might be way too long of an answer for that one. I have a lot of feelings about evaluation, but yeah, I think there's not a single must have. The most important is that you ask people locally what's important to them and you do that.
No, that's great. I'm sure, that person appreciates the thoroughness of your answer. I see we have a question here from Izzy. Please go ahead.
Hi, I'm Izzy. I'm a medical student at McMaster, my first year. Really excited to hear from you. I've followed a lot of your work. I was just interested, and you've sort of talked about this a little bit, but for those I'm interested in primary care, family medicine. For those like solo practice family physicians who don't have a link worker, who aren't part of a community health center, what are the strategies and what does the kind of future look like for demonstrating and getting almost the word out to those family doctors who have like 15 minutes appointments, are working off the side of their desk, that social prescribing could be really beneficial to them when they are sort of overburdened in that capacity?
Okay, so those dudes need teams. Okay, first, before they do social prescribing, they need a primary healthcare team, and some of that will be social, like social work and occupational therapy, and some of that stuff, and some of it will be a bit more clinical. But so yeah, there are models here in Ontario that can help. So there are some models. Trying to think if I forget the name right. There's a model called Team Care. That helps links individual or group, like small group practices of just physicians with community health centers, so that's your team. So even though you have your own practice, you can access the team. And there are also models that allow you to tap in, and this is in all the provinces, to things like 211, which is a database of community supports and services. So you should, be able to go online or call 211 and get support with an individual person and their social needs and make a referral onward through them. In Quebec, there's a website called Click Social that also is a bit like 211, has a resource database for individual social prescribers to access. Over time, I'm expecting and hoping that we will have more of that kind of stuff. Now that we're in a more of an AI era, we might leapfrog ahead in terms of the tools and databases that are available to individual people. But really, the fundamental is that we need to be practicing in teams at this stage. And so again, some of those more solo practitioners will age out and we'll be building in teams. Those who don't have the support, there are some of these ad hoc solutions. They're not that great though, and they're not that systematic. And so let's keep talking. If this is where you end up, then we'll figure out a solution that is better, but that's where we are.
Yeah, I would like to be working in a team, but thinking about those who are kind of existing in solo practice already. Yeah, but I appreciate the answer. Thank you.
Again, this is why the link worker type role is best served by not a registered health professional necessarily, but somebody who's from the community, a volunteer, a community health worker, a peer who is somebody who's in that community for the long haul and can do a lot of that work. So that, ideally we would be able to have, for example, let's say every Ontario health team has a link worker or two that a solo practitioner could refer somebody onto and then leave it at that. So, there will be solutions that emerge over time.
Yeah, just to segue from that great question and your answer there, we have one from Jessica in our question bank here. Do you think there needs to be any training or standardization for link workers? Like, what does that look like?
We already have some tools for that on our website at socialprescribing.ca. If you go to resources, we've got link worker sort of training roadmap and some tools. And they're also globally. So the World Health Organization Western Pacific has a link worker training, self-guided training program you can take. And there are some more hands-on, more detailed training programs available also in the UK. So yeah, absolutely. People need to have some basic level of training, but it doesn't need to be a full registered health professional degree. It can be a few hours of really focusing on motivational interviewing, active listening, how to do referral and support, some of the basic concrete components of working with both health and community folks, and those kinds of things. So it is absolutely something that's on our radar and that we're thinking about. And I think I'm just in general a little bit resistant to over professionalizing the role, and see, there are many like community colleges, for example, who would love to snap this up and create a new professional designation. I'm not sure that's the right approach. So it's something that we will keep investigating over time. But yeah, there are some basic skills about listening, about equity, about respect, about collaboration that are part of the role. So have a look at socialprescribing.ca if you want to see what we've come up with so far.
We definitely will do that. Yeah, thank you. Grace, you wanna go ahead?
Hey there, I'm Grace. I'm a fourth year student at MUN University in Newfoundland, and kind of interested on what Izzy had talked about, what you had mentioned about needing a team. And so I'm hoping to do a rural-based residency in family medicine next year, where we don't have the luxury of teams, obviously, in those settings. Like in the place that I've spent most of my time, we don't even have like an occupational therapist or a physiotherapist. And so I'm just wondering, like, what your suggestions are for trying to integrate social prescribing in those settings, but really not having much of a basis to go off of.
Yeah, well, and in those settings, attachment to primary care is pretty weak as well, right? So there's lots of people who don't even have that level of access. So this is where social prescribing can be initiated in different settings. So, for example, I have been working with food-related folks in Nova Scotia and in Newfoundland, actually, who have decided that they are going to focus social prescribing and food-related work not in primary care at all, but in employment and training centers, because that's where more people have a point of contact with government. So people who are going in for employment insurance, if they're seasonally employed, or other kinds of career-related supports, that kind of thing, that person that they encounter there, who's like an employment specialist or that kind of thing, can be trained as a link worker and can make referrals and be that point of support. So if you're a solo practitioner in a rural area, you have to look around and at your assets in the community. Where are their strengths? Where are their points of connection with people? Maybe it's in the faith community. Maybe it's in employment. Maybe it's in the food sector, like other places, and build those relationships. So when we help people start doing social prescribing, we always start with asset mapping, which is bringing as many of those folks together as you can who are willing and ready, and having a conversation about what resources are available in the community. It doesn't have to literally be a map, although it can be. It can just be a list. But you find out, where are people going? There's a community center, everybody goes to bingo, there's hockey, or whatever the things are. And then you start there, and you start with what's strong. You refer people there, and you just keep going. So it can be very grassroots. And there are some amazing examples of grassroots stuff from our first pilot project here in Ontario, in some very rural areas. So for example, in Temiskaming, where it's a very remote community, mostly Anglophone, but a minority Francophone, the French-speaking population had very poor connection to services and needed support. And once the people there who were doing social prescribing asked that group, what matters to you, what they found out was they wanted pet sitting. They wanted people to watch their pets so that then they'd be willing to go to their medical and social services and supports. Otherwise, they would not be leaving their houses. Nobody would have thought of that if they hadn't just asked. So pet sitting became like the whole point of social prescribing for this community. And then in other places, it's like, we created a bereavement support group in a small town where lots of people retired with their spouse, and then one spouse, passed away within a short time, and the other one had not much support. Creating some new thing where the bereaved folks are getting together to like eat together or do small things. So it can be, this is way long, sorry, I'm giving all these long answers, but yeah, it can be very creative, grassroots, and small. And as long as it's something that is strengths-based and feasible where you are and meaningful to you.
Okay, thank you so much. Really helpful.
Okay.
Yeah, thanks for your question, Grace. We're almost out of time, but we still have many questions coming in, so try to get through as many of them as we can. This may elicit another very long answer from you, because I know the successes are many, but In your experience, how is the relationship building with the community translated directly into tangible and sustainable improvements in healthcare outcomes? And that's a question from Niku as well.
Oh, that's a great question. It's a bit early for us to assess outcomes, but that's our expectation. And like I said, in the Alliance for Healthier Communities pilot, we did see, we measured outcomes that were like self-reported, but we do also want to lift up and validate self-reported PREMs and PROMs, right? Patient-reported experience and outcome measures as valid health data as much as any objective measure. But there are some great examples in the literature more broadly. So for example, diabetes-related social prescribing in the UK, they saw reductions in HbA1c levels. So you can, and there are some really good examples, but we're just not that far along here in Canada yet to really do that well. And most of the evaluation we're doing right now is more done by the community side, who really don't have an orientation to doing clinical outcomes. So it's a bit of a longer game. But we're in it for that long game. So stay tuned over the next few years as we, hopefully come up with some more outcome data.
It's funny you brought up the diabetes stat. That's one of the ones that we quoted in our article, actually.
Good one.
Yeah. We've got one more here from Zelda in the chat there. So she's saying, what role might, I guess, recreation therapy students play in supporting social prescribing initiatives for students to navigate and access the oasis of services on campus? Are there any resources or are there other implementations to look to?
That's a great idea. If you are a recreation therapy student, just start making stuff happen in your community. I have direct lived experience of this. Many of you know from some of my writing that my own daughter has gone through a big health crisis this year. And when she was hospitalized, particularly in the Holland Bloorview Kids Rehabilitation Hospital, had access to lots of social prescribing type services, recreation therapy among them. And so we really saw from that, our lived experience, how important it was for her to do things like play around with other kids in the gym, have pet visiting, bake cookies together, all those kinds of things. So lots of different health professionals have a role to play. I'd love to see the rec therapy students on campus take some leadership in helping to be link workers or otherwise support social prescribing initiatives on campus. The sky's the limit, really. It just depends on building good relationships on campus and being willing to be there for the long haul. And that's one of the challenges for students, right? You're there for a few years, but not forever. And so there also need to be some other institutional supports that you build alongside that so that it doesn't end when you graduate.
And just looking for frameworks, like instead of reinventing the wheel. I'm not an RTS student per se, but if I can bring a toolkit or something for that university setting, then it might be able to mobilize on.
Yeah, so let's talk, because that's part of what Nicole is really working on in the social prescribing on campus work.
Amazing. We're building social connections during a webinar on social. I guess just lastly, how do you feel about, in order to ease the healthcare system, we're now maybe shifting the burden onto community partners and organizations? Is that something that you're seeing?
Not yet. And I actually consider that a good problem to have. If we have enough social prescribing going on, that becomes an issue. It's not great. Social services and community services are already very strained and need lots more resourcing and support. But this is one way to build that. From my perspective, we'll be able to demonstrate the demand, demonstrate how they connect to the health system in a more rigorous, empirical way, and help build connections and trust between two sectors that don't necessarily have longstanding relationships. And so it's a bit of a long game. It's definitely going to happen that we have more demand than we have supply when it comes to community. And I'm interested in supporting the growth of that community sector and really building the resources and support. And I see the work of growing social prescribing as part of that. So, we may have some challenges along the way. I don't really see it as a huge concern, because my expectation is that funding and growth will sort of be iterative and grow together along the way. And if it does become a big problem where lots of people from health are being referred to social, that's news, right? And that's data, and that we can learn from.
Amazing. Just to round things off, do you have any last comments, any advice for us, anything you want
I'm
to
just so
convey?
heartened to see you all here. I love what you're doing. I think I'm very inspired and hopeful about what you have to offer and to bring into medicine, and to any other sort of medicine related fields that other folks around the table today are coming from. And I really want to support you and the work that you're doing. You know, the evidence shows social determinants of health matter. And I know you want to act on this. I wish that you wouldn't be encountering challenges and doing that along the way. You will. I want to be there to help and learn about what they are. So keep doing research amongst yourselves. Share what the barriers and challenges are for you as learners and as early career professionals. This is what I say to all my students, like, please take up space. We need your voices, we need your experiences, we need your diverse positionalities, and we need your medical training and expertise, and the authority you bring as physicians in training to really help move the needle on this kind of stuff. So thank you for being here. I want to keep supporting you.
Amazing. Thank you so much, Dr. Mulligan, for your time this evening, and thank you everyone who came. I encourage you to make this, not the end of our webinar, but the start of a conversation. Please join our group and get involved at the ground level wherever you are, and let's make social prescribing more of a reality. Thanks for everyone for coming, and have a wonderful evening wherever you are.
Thanks, everyone. Take care.